On inflammatory maculopathies. I don't have any financial interest in this. There's a variety of conditions with inflammation of the posterior pole, mainly the deeper retinal layers, as a common feature. We call this group of conditions as an idiopathic inflammatory maculopathies or the white dot syndromes. Now, the main challenge here is that in order to differentiate between these and arrive at the correct diagnosis, and also to explore some of the simulators. Once that is done, then there is not much challenge because the management is quite straightforward. So let me start with this case of a 30-year-old woman who presented with visual loss in the right eye of 1 week duration following an episode of viral fever. Her best corrected visual acuity in the right eye was 6/18 and left eye was 6/6. And you can see this lesions in the posterior pole, the characteristic placoid deep lesions. So the obvious things to do will be a fluorescent angiography, and we did that, and we saw that these lesions were initially hypofluorescent in the early phase, and the later phases they become hyperfluorescent due to leakage and staining. So we made a provisional diagnosis of acute posterior multifocal placoid pigment epitheliopathy, and the investigations there was nothing positive. We gave the patient a short course of systemic steroids. She responded very well, and within 3 weeks the vision was restored 6/9. This is not a typical case of APM PPP, because a typical case would look like this, where you expect it to be bilateral. At least it may not be bilateral to start with, but within 1 month it will generally affect the other eye also. And has got a relatively good prognosis and often doesn't require treatment unless it has got something like a serous detachment. Now this is a related condition which has got a little more subtler lesions, and the difference is that it doesn't actually involve the fovea directly. It is around the in the parafoveal region, and therefore the vision remains very good, and it's generally unilateral. There is a multiple evanescent white dot syndrome of mutes. This has got a very characteristic fluorescent angiography. In fact, it differs from the other white dot syndromes in that in the early phase itself, these lesions are hyperfluorescents, and if you look carefully at the hyperfluorescent dots, you can see that each of these is actually constituted by multiple small spots arranged in a wreath-like pattern. So that is one important finding by which you can differentiate this particular disease from the other white dot syndromes. Again, no treatment is required because there is a self-limiting condition, generally goes off without producing any problems. This was a 32-year-old female presented with blurred vision and floaters in the right eye of 1 week duration, and that eye the vision was 6/12, the other eye was normal. And slit lamp there was mild anterior chamber reaction, there was mild vitritis. In the right eye, explaining the visual loss, there were some few parafoveal active lesions, again at the deeper level. But the rest of the area also, in the periphery also, you could see some of these corroded patches, which is actually a little more older, which are sort of healed. And the same thing in the other eye, which is inactive lesions. So the one characteristic feature in this is that the pleomorphism of the lesion, you can see corroded lesions of different age, inactive as well as active. So this is a case of a multifocal choroiditis panuveitis syndrome, and some of these cases can lead on to this sort of picture where you have subretinal fibrosis, and if it is extensive, then that could result in irreversible loss of vision. And this is not an innocuous condition because it has got a chronic course, and so has to be managed aggressively. The activation has to be managed aggressively, and sometimes the patient can be left with a lot of complications like scarring, fibrosis, CNVMs, like that. This was a 50-year-old patient who came with, his complaint was blurred vision in the right eye, because he has practically given up on the left eye. He was actually a patient who has been followed up at the Shankar Nethralaya and was advised to consult locally in case of any problem between the follow-up. That is why he came to me. He was already on tab bisolone 20 mg OD. So we saw this sort of a disc edema here in the right eye, and the old photographs showed what was going on. You can see that in the left eye. This was an earlier picture of January 2007. You can see this very characteristic finger-like extensions. And the fluorescent angiography showed that these lesions were hyperfluorescent in the initial phase. They became hyperfluorescent later. The hyperfluorescence generally came off from the borders, and the active areas became intensely hyperfluorescent in the later phases. So this is a case of serpiginous choroiditis. And so, having seen these pictures, we knew that the same thing was going on in the right eye also, because that was what the patient was very concerned about. You can see again in the superior pole of the disc, this hyperfluorescent area. Okay, this hyperfluorescent area, it becomes hyperfluorescent later, and this is also the initial manifestation that the serpiginous choroiditis has started in this eye also. So that was what the patient was concerned about. He was already on bisolone 20 mg OD. We did the obvious. We started him on IV methylprednisolone 1 gram OD for 5 days, which was followed by tab bisolone 80 mg. He responded very well, became asymptomatic in 1 week itself. The thing is that this has got a very chronic course. It relapses. So for about 1 year he was okay. In between he had gone to again back to the parent institution when he had few recurrences, which I learnt, during which time he was even started on ATT. He had ATT for 1 year, and in the course of the next 1 year, this was the picture in January 2011 when he had further extension of these lesions in the right eye. And the OCT, I am just showing the OCT because it shows that the level of the lesion at the level of the RP level and the deeper retinal levels. Now, other than this, the OCT doesn't have much role. It just helps to pinpoint the level of the lesions. So at this point of time, we started him on tab azathioprine, also 50 mg BD, and he is just going on like that. We are keeping our fingers crossed. So talking about the investigations in these inflammatory maculopathies, FFA of course is the obvious choice. Then ICG is more of an academic importance, but it shows those lesions much more better. OCT helps to pinpoint the level of the lesions, and it also helps to detect if there are any serous detachments, CNVMs, then it excludes some other simulators like VKH, and you can manage accordingly. Now, one investigation which has recently gained popularity is autofluorescence, because it is one investigation which can highlight the areas of activity without the need of any invasive investigation in this case. This is a case from the literature, a case of serpiginous choroiditis, where you can see that the autofluorescence picture has sort of brought out the area of activity very clearly. So this is a non-invasive technique, and so it's very useful in following up these sort of patients. Now, other white dot syndromes like this birdshot retinochoroidopathy, Azure, retinal pigment epithelials are rare, and I am not going into the details of that. Some other inflammatory maculopathies has also to be excluded when you are talking about these inflammatory maculopathies before concluding that they are idiopathic. This particular condition presented like this, I was not able to diagnose it correctly in the first day, but the second day I knew that there was something here, which then of course moved on to this area, by which time I could try it. So this is a case of DUSN. And some other cases like this, VKH, also comes in the different diagnosis. These sort of conditions has to be excluded before you confirm the diagnosis of the white dot syndromes and manage accordingly. As far as the management is concerned, corticosteroids is the mainstay of management. The only question is when to give and when not to give. Because many of these conditions like APM, PPP, MURS, etc., they are generally not indicated unless they have got a massive serous detachment, something like that. But other chronic conditions like the multifocal choroiditis, panuveitis, serpiginous, etc., they have to be used, but used in a quite judicial way, because many of these are chronic conditions and will require long-term steroids. Now, antimetabolic like cyclosporin and azathioprine has also to be employed in conditions like serpiginous, especially when it doesn't respond very well to the steroids and as a method of steroid sparing agents. Okay, thank you.